everyone. My name is Sam Alborz. I'm a full-time practicing endodontist in Knoxville, Tennessee, which is located in East Tennessee. And I have 2 office locations. I work 5 days a week, and in short, I love what I do. And before I begin tonight's lecture, I'd like to thank Colteen for sponsoring tonight's event. And also, it's a privilege to be among all of you, my colleagues around the nation and wherever in the world you may be. I picked the topic of endodontic irrigants because I think it's a topic that is not emphasized enough. I think there's a lot of emphasis from different manufacturers on different file systems, and I think everybody has their filing system down, but without cleansing the canal, we're not really accomplishing anything. In order to keep you awake tonight, I'm going to share some pictures with you of some of my hobbies. This is scuba diving in the Southeast Pacific. This is some of the fish you may find there. This is a clown trigger fish. Also enjoy going on safaris to Africa, and this is a typical day in the bush. And these are some of the animals that you may encounter. And really, that's why I go. What we do know about microorganisms and apical periodontitis is that apical periodontitis is caused by bugs and bacteria, and that was a classic study that was done by Kakahashi, Stanley, and Fitzgerald, and where they had germ-free rats that had their pulps exposed. They did not develop apical periodontitis, and those rats that had bacteria in their mouth and their pulp exposed did develop apical periodontitis. So we know this for a fact, and we know that root canal anatomy is highly irregular. And despite your best efforts, I mean, you can file all day long, but you will not achieve cleansing. So we truly rely on chemical disinfection of these canals in order to be able to accomplish our endodontic therapy. We were always taught in dental school that cleaning and shaping, and I really dislike that term because shaping paves the way for cleansing. So your files shape and your irrigants clean. Always remember that. And so the two are really go hand in hand in accomplishing our goal of achieving a clean canal. This is a study that came out in the Journal of Endodontics a few years ago. What they did is they took a maxillary molar and they shaped it with the best file system out there, and I won't go into the details of it, but 06, 08 taper, 35 to 40 at the apical aspect, and they basically discolored the tooth, if you will, and made a CT scan. And you have your palatal root here, you have MB, DB, and this is your MB2 canal. All the areas that are shaded in green were areas that the file did not touch. So as you can see in the MB2, that is a slender canal, the file did not touch the canal. So we truly rely on the chemical disinfection and the liquids to seep into these crevices and different nooks and crannies, if you will, for lack of better words, to debride these canals and get rid of all the bacteria that may be hiding everywhere. So this study really truly made a lot of noise. So some of the contents of that we may find within the canal, of course, is your pulp tissue, whether it's necrotic or vital. We have all different inflammatory mediators within the canal that have been secreted during this inflammatory process. We have different kinds of bacteria, fungus, virus. All of these things have been found within the canal. And not only is it the bacteria that we're dealing with, but also their endotoxins and also the DNA and RNA that they may be leaving behind. A lot of the studies today in endodontics involve actually grinding up the dentin and looking for strands of RNA and DNA of bacteria that may be left behind after chemical disinfection. We used to, once upon a time, just take a sample, put it on a petri dish, and see what we can grow. But that's not really the gold standard anymore, because we know that DNA and RNA can survive and therefore replicate years later, and that's where you get failure of a case. So what else do we find inside the canal? Also the previous obturation material if you're doing a retreat like my cases. all sorts of goodies. That amalgam you went through, the composite you went through, all these things are within the canal system that we have to remove. So what are we looking for when we talk about a good endodontic irrigant? What are the properties? Well, it has to be broad spectrum. It has to kill all these things that we talked about: bacteria, fungus, virus, their endospores, their DNA, their RNA, everything they may have and leave behind. And it has to inactivate the endotoxins and the spores that these guys may leave behind. And also at the same time, it should not form a smear layer, and we're going to talk about that and what smear layer is. But one of the most important things that we're looking for in endodontic irrigant is dissolution of pulpal tissue. We have to dissolve pulpal tissue. And hopefully that irrigant will be a lubricant for us, so we have less friction and less separation of our files. And at the end of having all these wonderful properties, we want it not to be toxic to the periapical tissue and not to, God forbid, cause any anaphylaxis. We have a lot of expectations of this endodontic irrigant, so let's just move on and see what we have. One of the things that I'd like to point out to you is volume irrigation. It is accepted today, unanimously in endodontics today, that we have to use large volumes of irrigation. It is very important to flush out everything out of the canal and also introduce new endodontic irrigant into the canal constantly, because it quickly gets inactivated by dentin and dentin inhibition. There's a vast number of endodontic irrigants on the market. I mean, saline was introduced at some point. You all have it in your offices, is readily available. And, of course, it doesn't damage the tissue. It's great for flushing stuff out of the canal. By virtue of being a liquid, it will, of course, lubricate canals and reduce stress on our endodontic files. But the main problem with saline is that it does not degrade or dissolve pulpal tissue. And also it cannot decontaminate canals because it really has no antimicrobial properties. So saline is not really a great endodontic irrigant. But the main reason I brought it up is for these studies that were done using saline alone. Just the act of flushing the canal in and of itself was able to reduce the bacterial content by 40 to 50%. So these are all studies to support flushing of the canal and the use of volume irrigation. If I do a mediocre endodontic treatment, but I use, let's say, 3 times the amount of endodontic irrigant than dentist B, and that dentist does a wonderful endodontic therapy, but only uses 2 or 3 cc's of hypochlorite, for example, my case will probably end up doing better because I used a larger volume of irrigant. When we talk about irrigation, we are predominantly talking about positive pressure irrigation. You put a solution in a syringe, you load a needle, and you push positive pressure. It is very important for you all to consider using this type of endodontic irrigation tip, and that is a closed-ended, side-ported needle, because we do not want to push the endodontic irrigant out of the canal, because you know what happens if we do that. This is another schematic version of that, and the reason I have this diagram here is to show you that most studies today agree that the endodontic irrigant will only move past this type of needle, the side-ported needle, by 1 millimeter. What does that mean? That means that, and I see this in a lot of offices where the assistants put the fold or the bend in the endodontic needle prior to giving it to their practitioner, to their doctor. Well, let's say you have a 20 millimeter working length on a tooth number 9, and you put the needle and you put a bend on it at 15 millimeters, 1-5. That means the apical 4 millimeters of that canal are not getting irrigated, because the endodontic irrigant only goes past the needle tip by approximately 1 millimeter. So that's really, really important. If we are not irrigating the apical 1/3 of the canal, we will not achieve healing. And here's another diagram of that. Now, please don't go to your offices tomorrow and grab the endodontic needle and put it all the way down the working length and push, because if you do, we're going to have some problems, and you know what that I'm talking about. Another important factor that I'd like to point out in regards to irrigation, that is passive irrigation. Please never, never, never engage the needle within the canal. While I irrigate, my hand is constantly in an up and down motion. And I'm doing that, one, to agitate the solution, and two, I'm doing that because I want to make sure that I am not binding this needle within the confinements of the canal. Because if I do, and I push, I will probably push the endodontic irrigant out of the apex and have a nasty, nasty event, such as this young lady here. For some reason, the sodium hypochlorite was pushed out the apex. She had what we call a hypochlorite accident, severe edema, burning of the tissue, as you can see. And this I'd like to talk about this hypochlorite accident. And the reason I bring this up is because we use a file to achieve patency within endodontics. What does that mean? That means we take a 10 or 15 file 1 millimeter past the working length to make sure that we have not packed debris ahead of ourselves and blocked ourselves out. That's to make sure that we are patent. And are we pushing hypochlorite out of the apex at that point? Absolutely. So why are all of our patients not looking like this? Because what we know today is that probably this patient had an anaphylactic reaction to hypochlorite, and that's why this awful thing happened to her. So I just want to point that out. This is, I was privileged enough to go to the Serengeti National Park last year and Tanzania, and I saw the great migration of wildebeest, and it was truly a once-in-a-lifetime opportunity. A lot of crocodiles, a lot of this kind of stuff going on, and you know, the Serengeti is a beautiful place. If you ever have the opportunity, please go and enjoy the wildlife that is being preserved. Okay, we shift now to another endodontic irrigant that is probably one of the hottest liquids on the market right now in endo, and that is chlorhexidine. This is 2% chlorhexidine. It is not the 0.12% that you guys use in perio. It's fantastic. It's fantastic at killing bacteria, and one of the main reasons, again, we use it here in endodontics is because of its substantivity. Again, it's broad spectrum, which is what we want. It attaches to negatively charged cell membrane portions, causing cell lysis. We use it again because of its substantivity. And it's pretty low-grade toxicity to the periapical tissue, which is really good. And its efficacy is comparable to hypochlorite. These are great, great attributes of this endodontic irrigant. So the question is, why don't we just use this all the time? Well, we're going to get into that in a moment, but there's a lot of studies to support that the hypochlorite and chlorhexidine used in conjunction with one another is more effective than either component alone. Zender is a microbiologist / endodontist out of Switzerland, very reputable researcher, and he did a review of the literature and made a suggestion to all endodontists and said, hey, this is what I recommend based on a review of the literature on our irrigation regimen. Let's use hypochlorite throughout our cleaning and shaping. Let's use EDTA to remove the smear layer, and make chlorhexidine your final endodontic irrigant. We got happy. We said, yes, this sounds like a great idea. The research is there to support it, and we started using it, and this is what happened. When the chlorhexidine came in contact with hypochlorite, there was a reaction, and this reaction formed a precipitate. And it's a nasty, the gunky brown slime that builds up within the canal and within the pulp chamber. It is not something that we want. And they did a study to show this and as to why this is happening. And this made a lot of noise in our field of endodontics. They took these microtubules and put sodium hypochlorite, this is saline, in increasing concentration from right to left. So as we move to the left of your screen, the concentration of hypochlorite was increased, and they added 1 drop of chlorhexidine to each one of these microtubules, And as you can see, as we ascend in the concentration or increase in the concentration of hypochlorite, the precipitate formation was more intense and thicker, and there was a stronger reaction that takes place. The precipitate is called parachloroaniline, PCA. It's something you really don't want within the canal. There's a lot of studies now that are talking about possibly this thing being a carcinogenic kind of material, so you really don't want it, and it's very easy to prevent this. Use your hypochlorite, and before you introduce the chlorhexidine, you may flush the canals with saline, with sterile water, or you can simply dry the canals with paper points, and also make sure your pulp chamber is dry. You do that, if you add the chlorhexidine, you will not have this issue. One of the ways to aspirate the irrigants out of these canals is either, again, with a lot of paper points, which may be wasteful, or you can use one of these Surgitip Endos by Coltine. It's a fantastic invention. We use it routinely in our practice, and this way you use minimal paper points, and it's very effective when you're interchanging different solutions, as we have to do. One of the main disadvantages of chlorhexidine is that it cannot dissolve pulpal tissue. Again, we keep coming to this, and that is the drawback, and that is why we cannot exclusively use chlorhexidine. I named this slide Never Wake Up Sleeping Male Lion. We caught up with this guy, and he was fast asleep until we pulled up in an open safari vehicle, no doors, no windows, and he woke up and he smelt the air, and we thought, uh-oh, we are in trouble. But really what he was doing, he was just guarding his pack, his family. There's a pride of 17 lions, and people ask, how close can you get to these guys? Well, this little guy was actually chewing on the tire of our vehicle, literally right next to my foot. So, with that being said, what is the best endodontic irrigant on the market today? Here it is, ladies and gentlemen. I know this doesn't seem very exciting, but sodium hypochlorite, yes, Clorox, which may be available anywhere all around the world in some way, shape, or form, is the best endodontic irrigant. A little history about it. Hypochlorite, has been around for hundreds of years. And as far back as World War I, there were surgeons that were diluting sodium hypochlorite and using a buffered solution to clean open wounds. They didn't have a lot of hypochlorite accidents. These people lived. So again, this kind of goes more towards the fact that these folks that have hypochlorite accidents probably have an anaphylactic type reaction. Chlorine, as you know, is widely distributed on Earth. It is never found in its free form. It's bound to something. And in the human body, it is part of your non-specific immune response, and it is secreted by neutrophils. Sodium hypochlorite, well, it is broad spectrum, non-specific bactericidal, kills viruses. It will kill a fungus also. It takes a while to do that, contact time, and its most important reason why we use it in the root canal system is because of its ability to dissolve pulpal tissue, whether vital or necrotic. Please keep in mind that necrotic tissue is a lot easier to dissolve, while vital pulp tissue is a little bit more fibrous and more difficult to dissolve and takes more time. Hypochlorite is very inexpensive, which we love to hear as dentists because everything we buy is so expensive. Has a great shelf life, and like I said, readily available. You may use the grocery store brand if you wish. A couple of points on that. One is, don't buy a huge tub of hypochlorite and leave it in your office for 3 years, because it will probably be ineffective by the time you really need it. It is very light sensitive, so you cannot expose it to light. I go to a lot of offices and I see the staff are kind enough to draw a lot of syringes of hypochlorite and leave them in the drawer for when and if they need it for endo. Well, that's probably ineffective. In our office, we draw hypochlorite the morning of for the morning patients and in the afternoon for the afternoon patients, and we use this hypochlorite, which Coltine makes. It has a detergent in there to reduce surface tension and allow for better penetration of the solution into the lateral dental tubules, which is primarily where most of the bacteria are hiding. There's a lot of talk among folks as to what concentration of hypochlorite should I use. Should I use it full strength? Should I dilute it by 50%? By 1 to 10? Well, there's no great answer to give you. I'm going to show you some studies here to show you what the different concentrations do. As far as antimicrobial activity is concerned, 5% and 0.5%, so full strength and 1 to 10 is about equal in its efficacy against bugs and microbes. As you can see here in this chart, you have 1% sodium hypochlorite, 50% diluted in full strength, giving you between 99 and 97% reduction in bugs. And I say bugs because there's a broad category of bacteria that we're talking about. In this study, you can see that the focus was on Enterococcus faecalis right here. And the reason for that is that we have a lot of emphasis in that in the literature right now, because E. faecalis is always present in every secondary endodontic infection. Every retreat case that you go into, there is Enterococcus faecalis present. Now, we don't know if it has virulence or the ability to cause disease, but we know that it is always present. As a result, a lot of the studies focus on this bug as far as eliminating it from the root canal system. Another study here that shows that lower concentration of hypochlorite is only capable of dissolving necrotic tissue, like we talked about. So if you want a vital case, you've got irreversible pulpitis, you did a composite, number 4, MO, it's hot tooth, it's angry, probably want to use a higher level or higher concentration of hypochlorite to dissolve that tissue. Here we have a study showing you again that 1% and 6% were both almost equally successful in eliminating E. faecalis. I don't want to bore you with a lot of these studies, but now some folks are just simply not comfortable with using sodium hypochlorite full strength. So what can you do to compensate for that? Well, one of the things you can do is increase the temperature of sodium hypochlorite. And we do that routinely in our practice. We warm our hypochlorite syringes prior to use. And you can do that in many different ways. There is something called a syringe warmer that you can purchase. Basically draw up your hypochlorite in a syringe, put a cap on it, and throw it into this thing. And you turn the switch on, and it keeps the syringes warm until they are ready to use. And also you can see that the syringe holders are kind of covered, and so that minimal amount of light will transmit and inactivate the solution. So these are little facts that I think a lot of people didn't know about hypo, and they just kind of drew it into a syringe and left it in the drawer, thinking that, you know, it's just as effective as when you first draw it, but that is not the case. A great study here that talks about, you know, a 1% sodium hypochlorite solution at 45 degrees Celsius dissolve pulpal tissue just as effectively as full strength at room temperature. So if you're just increasing the temperature by 25 degrees Celsius, which is not that hard to do, you can increase its efficacy in dissolving pulpal tissue and also increase its ability to kill bacteria. So it becomes a super atomic bomb when you warm it up. Just as simple as that. Took regular hypochlorite, we just warmed it in a warmer, and here we are. Now you don't want to boil the solution. Please don't boil it or anything like that. But even a warm water bath would be just fine. So the main downfall of sodium hypochlorite, because it fulfills all the other properties that we expect of it as an endodontic irrigant, the main downfall is the fact that it cannot remove smear layer. And we keep talking about smear layer, smear layer, smear layer. What is the smear layer that we keep repeating? Well, it's a mishmash, if you will, of pulp tissue, dental shavings, odontoblastic processes, cell processes, all the bacteria that we talked about, fungus, virus, the amalgam you went through, the composite you went through, the PFM kind of crown that you may have gone through, and not only the bacteria themselves, their byproducts, their spores, everything, and all the gunk that you generated on your file is now smeared all across the walls within the canal. And incidentally, you see this file right here on this picture. You see all the debris. Please never put that file back in the canal. After every pass within the canal, we take our files out and we basically stab them into a sponge. It's a sterile sponge that's been previously sterilized, thereby removing the debris from the canal, because if you put that file back in the canal, you will probably separate that file because of friction. And if you're having any trouble getting the debris out of the file with this sponge, which most of the time you will not, use a alcohol gauze and kind of go counterclockwise to clean the file. I thought maybe that might be helpful during your clinical cases. And this is a SEM, scanning electron microscope image on the left, as you can see, with the smear layer not only smeared on the walls, but also it has been pushed laterally into the dental tubules. And also on the right is a closer-up picture of that, showing how occluded these dental tubules are. There was a lot of talk even when I was in residency about, well, you know, should we just leave the smear layer alone, not disturb it? You know, it's sleeping there. Why do we want to disturb this thing? And right now in endodontics, you know, we're in agreement that it has to go. And the reason for that really mainly is that the smear layer, if we leave it there, it kind of prevents the penetration of the endodontic irrigants into the dental tubules, which again, that is mainly where the microorganisms are hiding laterally. It also prevents a good obturation and a good seal. And after you obturate the case, it starts to degrade and fall apart, the smear layer, thereby creating an avenue for leakage and recontamination of the canal. So we're in agreement today, unanimously, across the board in endodontics, no matter where you practice in the world, that the smear layer has to be removed from the canal. Well, some of the ways we do that is that we use chelating agents. EDTA is the one that's the most famous, if you will. Ethylene diamine tetraacetic acid. That's the one we all use in dental schools, and believe it or not, it's still being used today, and it's an excellent, excellent chelating agent. Citric acid, just as good as EDTA, just never really got that famous. It did not get popular for some reason, but it is available through some manufacturers. And MTAD. MTAD was created by Dr. Turabinejad out in Loma Linda, California. An excellent endodontist, brought us MTA, a wonderful material that we use for repair of perforations and one-visit apexifications and so on and so forth. But MTAD in and of itself was not a great endodontic irrigant, and very expensive and technique sensitive, and had a lot of issues, which I really don't see the need to use today. So these chelating agents remove the inorganic portion of the smear layer for us, and these are just some of the different chelators out there on the market. As you can see, on the left is MTAD, which I really don't think there's a need to use. Citric acid, just as good as EDTA, just not that readily available. And EDTA, 17% EDTA, is a wonderful, wonderful thing to use. I highly recommend it. I just can't imagine doing endo without using EDTA today. EDTA, like we said, it will open these dental tubules for you, and thereby allowing the irrigant to penetrate laterally into the dental tubules. And once you have these open tubules, you can now achieve a better obturation. And the way they do that is they form these internal complexes with the metallic ions, thereby demineralizing the superficial layer of dentin and washing it away along with the smear layer. Okay, that's kind of the mechanism by which they work. And once you have done that, again, you have nice smooth walls, which you can see under the microscope. We work under microscopes all day. We have open dental tubules and a far cleaner canal. This is just a picture, a scanning electron microscope showing you kind of before and after. So before would be the upper portion of the picture. As you can see, all the bacteria and the biofilm that is connected and adhered to the canal wall itself. So this portion would be the canal wall. These are the dental tubules that run laterally into the canal, and as you can see, there's tons of bacteria that we can see, and also elsewhere within these canals. And another reason, folks, that we talk about apical enlargement of the apices, meaning using a larger master file or apical file, is because we want to remove the affected dentin within the apical aspect of the canal, because that's where the bacteria are hiding laterally. So we want to enlarge laterally so we can remove the affected dentin and thereby remove a large portion of the bacteria. And the few that we cannot get to, that's when we rely on the chemical disinfection of the solution and try to get it to go laterally to kill them all. Sounds awful, but that's something we have to do. Some debate in our field as to how long do we actually leave the EDTA in the canal for. Typically right now, a 1-minute application of EDTA is a great thing. You know, if it becomes 2 minutes, I guess it's okay. But you don't want to put the EDTA within the canal and then get up and go do a hygiene check, and the hygiene check becomes your best friend, and now you're talking about sports, and how's the family, and it's been 10 minutes, and this thing has been soaking within the canal, and you then have peritubular erosion, and you can cause some pretty major damage with the EDTA being in the canal for too long. However, please do not leave it in there for less than 1 minute, otherwise you have not fully removed the smear layer, and you have not demineralized that superficial layer of dentin. Some more debate about the volume of EDTA. How much EDTA do we use? Okay, we know we have to leave it in there for 1 minute, but how much EDTA do we have to use? And a lot of studies agree that maybe 1 milliliter per canal is a reasonable volume to use. Again, this is not rocket science. I'm trying to give you some simple formulas that are applicable to your day-to-day clinical activity. So if you have a molar with 4 canals, probably a 4 cc syringe is a good idea. In our practice, we believe in volume irrigation, and I believe in volume irrigation even for my EDTA. I use 4 cc's for no matter what the case is. If it's a central, it's going to get 4 cc's. If it's a 4-canal molar, probably 4 cc's. If I have a 5-canal molar, hey, probably 6 cc's of EDTA. We're going to really flush it, leave it in there for 1 minute, and then get it out and add hypochlorite. Going back to this diagram that I first showed you, now you can see how important it is to rely on the chemical disinfection of these canals, because a lot of these areas within the root canal system are inaccessible with our files. All the green areas, and this is in the palatal root, is inaccessible. The MB2 completely inaccessible by files, meaning that the rotary barely is able to bind any portions of the canal wall because the canal is so slender and so slim. The MB2, for those of you who do maxillary molars, just so you know, today in the literature we have solid evidence to show that the MB2 is present between 50 to 90% of the time in maxillary first and second molars. So if you are doing maxillary molars and you are not finding 4 canals, we are probably in trouble. In our practice, it takes me minutes to find MB, DB, palatal, shape them, clean them, I'm ready to go. It will take me 15 minutes sometimes to find this little guy. But it's there, and we find them. And we find them because we use high-powered endodontic microscopes and surgical microscopes. I just want to point that out to you. And also expect them in your maxillary second molars also. So most of the time, if you have failure of a case and it comes back to you on recall or any kind of hygiene check, it's the MB, the mesiobuccal canal, that is failing because of the complex anatomy that it has. One thing that I'd like to briefly talk about is hypo versus EDTA. I frequently hear and used to hear from older practitioners particularly, I use hypochlorite and I go EDTA and I go back and forth to kind of soften the canal and so on and so forth. And that is about the worst thing anyone can do, and the main reason for that is that hypochlorite and EDTA neutralize one another. So if you are going back and forth between the two solutions, you are not allowing either solution to work. So we only use hypochlorite, then we only use EDTA, and so on and so forth, and we don't go back and forth. And I will go through a regimen for you for your case tomorrow morning right before the holidays, that your patient's going to walk in with pulpitis and you're going to help them and you're going to be a hero, and I'm going to show you exactly how to do that towards the end of this lecture. This is a relatively newer area of research, and there's some preliminary studies being done on a different chelating agent. EDTA is wonderful, it really is, and I will probably continue to use it until something better comes along. But there's been some studies done on phosphoric acid, and this is not it is 37% phosphoric acid, but it is not in a gel form that you all use for your bonding system, but rather this is a liquid form, and it's been showing some promising results, especially in the apical 1/3 of the canal. So kind of keep your eyes and ears open in the future for phosphoric acid to make its way through, possibly as a chelating agent. I like to be true to my audience when I speak. These are the most recent slides that I have been able to put together for you all. And this study just came out in the Journal of Endodontics, and it talks about the inhibitory effect of dentin. So dentin inhibition, which is huge, and it affects endodontics, it affects your bonding system. You all know this, you deal with this as general practitioners, I don't have to tell you that. And the way they did the study is they took pulpal tissue and dropped it in a cup, if you will, of sodium hypochlorite, and in 1 hour they had total, complete dissolution of pulpal tissue. The same thing with calcium hydroxide. But when they added ground up dentin to the same solution, so they had hypochlorite sitting in a petri in a cup, if you will, dropped the pulpal tissue in there and added ground up dentin to this thing, after 1 hour that pulpal tissue was not fully dissolved. That calcium hydroxide did not fully dissolve the pulpal tissue. The point of this study is that on your nasty cases, those cases with a large radiolucency, those cases that are hyperemic pulp that will not stop bleeding, the major pulpitis cases, you cannot rely on one-step endo. We do a lot of our cases in 2 visits because you simply cannot achieve complete disinfection and dissolution of the pulp tissue in that 1 visit on your nasty cases. So don't be shy, do use calcium hydroxide, and do the right thing, because you're the one who's going to be putting the crown on this tooth, and you're married to that patient for the rest of your life. And they're going to come back every week and say, when I bite down it hurts, and when I flick my tooth it hurts, and so on and so forth. So any doubts in your mind, please use calcium hydroxide. Make sure you tease it all the way down to the apex with a file. Put a sterile cotton pellet and seal it up with a provisional restoration of your choice, whether it be Cabot, Duotemp, glass ionomer. Duotemp is a wonderful thing that Coltine has, which is basically Cabot that is curable. So everything we talked about thus far in our irrigation system was positive pressure irrigation. You put the solution in a syringe, you pushed with your needle, and there's positive pressure irrigant coming out of the canal. This is called the Canal Pro Irrigator. What this does is kind of the best of both worlds. This is based on negative pressure irrigation. So that's a simple syringe that you see there. It's a 5-6 cc syringe. You fill it up with hypochlorite. The little tube is connected to your suction, and you put this inside the tooth and you push. And what that little cannula is doing is this is pushing the solution out here, and this is suctioning it out this way. So this is based on negative pressure irrigation. So everything is circulating in and out of the canal constantly. And some of the advantages of this system are, one, you have minimal chances of pushing hypo out the apex, so it reduces significantly your chances of a hypochlorite accident. One. Two, you can use a very large volume of irrigant without having to worry too much about, ooh, did I push too much? Is this going to hurt the patient or what have you? You just keep pushing and it will come out and aspirate itself out of the canal. A wonderful, wonderful way of debriding the canal. There are different systems out there. This is called the Endovac system by another company. It's a little bit more complex. Again, you have the syringe here pushing the endodontic irrigant into your access opening. There's two aspirators, if you will. This is the one that does the coronal 1/2 of the canal. And once you get down towards the apical 1/3, the nitty-gritty, you use this micro cannula right here. This will go down to the apex. And so your assistant will be dripping the hypochlorite into the pulp chamber with this thing. You will be aspirating with this guy. And again, this is based on negative pressure irrigation. The issue with this system is that micro cannula is 32 microns. So for you to be able to get this into the apical aspect of the tooth, so the apical 1 millimeter, if you will, you have to enlarge that canal to a size 35, ideally probably a 40. Now, I don't know about you, but taking a mesiobuccal root of a maxillary first molar with an 80-degree dilacerated root to a size 40, that is tough. It is tough to achieve that. Hand files, stainless steel files will want to straighten up on you. Nickel titanium files may fracture. Probably you may want to consider using some kind of memory type file, and like a HyFlex CM file that will probably be able to achieve that for you. But nevertheless, taking a mesiobuccal root of a maxillary molar to a size 40 is difficult, and that's the challenge with using this system for your irrigation. But again, lots of studies here to support this. Craig Baumgartner, endodontist / microbiologist out of Oregon. Excellent endodontist, fantastic studies. And you know, he said that the 1 millimeter and 3 millimeter level from the apex, it was fantastic debridement of these canals using the Endovac and the negative pressure system. One of the probably hottest topics in endodontics right now, in addition to chlorhexidine that we talked about, is acoustic streaming. This is a concept that's been around in engineering for a long time, and it has made its way into endodontics. The studies are phenomenal. And what this really is about the application of energy to a solution. Energizing the solution through sonication and cavitation. So you apply an instrument that oscillates within the canal at a high frequency, such as an ultrasonic tip, specially made tip, and that vibrates within the canal, like here, and that creates effervescence, or bubbles, that travel in the main canal and into the lateral canals and accessory canals. And what they do is the implosion of these bubbles off of the canal wall will knock the debris and the biofilm off the walls and into the solution, where they die. The microorganisms, anyway. And the research behind this is solid. Solid. And there's several devices out there that help us achieve this goal. But we do acoustic streaming on every single case, every single irrigant. I'd just like to bring your attention to this diagram here on the left. When I'm working, when I'm filing my canal, whether it's hand or rotary instrumentation, my canal is always flooded, just like that. Why do I do that? One, I have chemical disinfection going on at all times throughout the procedure. Two, I minimize the risk of separating instruments. Keep it flooded, ladies and gentlemen, keep it flooded. Canal Pro Ultrasonic Irrigator, a device offered by Coltine. It's worth every penny of investment. If you do endo in your practice, if you think you're an endodontist and you're very comfortable with what you do, you don't want to see failures, please use acoustic streaming. This is a kit. It hooks up to your ultrasonic unit. You are constantly feeding endodontic irrigant through this little tube that is attached to a syringe. Your assistant can be pushing that. This has a NiTi tip that is reusable and autoclavable, and you place this within the canal. You put your foot on the pedal, and off we go. 25,000 kilohertz, 30,000 kilohertz, and you allow that thing to oscillate and to sonicate and cavitate that solution and apply energy to it and get rid of the bacteria and the biofilm. I cannot tell you how important it is to utilize this technology. Here's another diagram of that. Other devices on the market is an endo activator. I believe it's made by Tulsa, by Dentsply, excuse me. The issue with this one is that it is sonic energy, so it's a lower level. It's not ultrasonic. It goes, I believe, 3,000, 5,000, 10,000 kilohertz. It is not fast enough. It is not a bad thing to use, but it is not quite as effective as ultrasonic energy. Another thing that I believe in truly, and I highly recommend if you do some endo in your practice, is of course you would buy these bottles of hypochlorite and EDTA and chlorhexidine offered by Coltine in a very clean way, and they have these fill stations, and you take the bottle and you flip it upside down in here. You don't get one drop of mess. You screw your syringe into this, aspirate what you want, unscrew it, and off you go. And it is kind of light protected, as you can see, and so is the bottle. Highly recommend these. We have tons of these in our office and we love them. So, tomorrow morning, you have the patient that's going to come in. It's Christmas and they want you to get them out of pain. What are you going to do? Doctor, please help me. You apply the rubber dam. Please, please apply a rubber dam. I beg you, please apply a rubber dam. You use hypochlorite throughout your procedure. You shape the canal and you are happy. You fit your cone, take your PA. I'm happy with this master cone. I'm going to pack this case. I am not going to instrument anymore. Remove the hypochlorite via those micro suctions that I showed you. Add EDTA for 1 minute. Probably tease it down with some ultrasonic energy or with a file. Make sure you get the EDTA to go all the way down. Remove the EDTA. Add hypochlorite. Why am I doing this? One, because I want to inactivate the EDTA, and two, I have these wide open dentinal tubules that I want my hypochlorite to go into and penetrate. And for my nasty cases, I'm going to dry the canal or rinse it with some saline and finish with chlorhexidine. Dry the canal and pack your case. I'm going to leave you with this picture here. I went to Zimbabwe, and the main reason I went to Zimbabwe was for this elephant alone. It's an area called Mana Pools, M-A-N-A, and they eat all the vegetation on the lower levels. This elephant, his name is Boswell, is the only elephant that can do that. He has a 30-foot reach right there, and he's able to bring down very large branches that have nutrition in them and some green leaves, and he enjoys it. And he's the only bull that can do that, and all the other bulls stand around and watch him do that, and he does not share, and he's a grumpy old man. Thank you so much for your attention. I'm going to try and answer some of your questions. You've been a great audience. You really haven't made a sound, or maybe you did and I couldn't hear you, but I truly appreciate all of you. Let's just see some of the questions that we have from Emilio. Emilio says, is waterlays good for endo? Emilio, to this date, no. I'm afraid nothing to back that up conclusively. Unfortunately, we're still doing a lot of research in that area and the photodynamic theory and so on and so forth. So we're not quite there yet. That's a great question, though. I've never been asked that question. Giovanni says thank you. Well, thank you, Giovanni. I appreciate you. We have Nasreen. Nasreen says, what do you use to clean the file during treatment when the sponge is ineffective? I did point that out. I highly recommend the sponge. We have a large metal cube that we have a sponge pushed into, and I just basically stab my files in there and clean them. I give them to my staff. This is any debris. They will inspect them and rotate them in the light, and if they see any debris, they will use an alcohol gauze 2x2, and they go counterclockwise and pinch that, and that a lot of times is very, very helpful. Also, your staff gets a chance to view the file. Teach them what a bad file is. If there's a shiny spot in there, if it's unwinding or twisting or anything like that, then they can bring that to your attention. Okay, it's very important. That way you reduce the chances of separating a file. We have Victor. It says here, have you ever used hydrogen peroxide? Excellent, excellent question. I love these questions. Hydrogen peroxide really has no effect on the canal. Really, there's no dissolution of pulpal tissue, minimal antimicrobial activity as far as we are concerned. I'm going to tell you a trick, but please don't use it because this is anecdotal. This is just from me to you. If I have a bleeder that will not stop bleeding and I know I've really cleaned the canal, I sometimes use a little bit of hydrogen peroxide, and that effervescence and the bubbles help sometimes get a little bit of hemostasis. And if I can dry it with a paper point, then I'm packing the case. If I do that, and I dry it with a paper point, and there's still bleeding or heme, I will not pack the case, and I will place calcium hydroxide within the canal, bring the patient back. Please don't push it. If it's bleeding still, go ahead and bring the patient back and reappoint them with calcium hydroxide. Let's see. Another question here from George. Why not use EDTA as a lubricant, then hypochlorite? Excellent solution, George. Excellent question. George, EDTA softens the dentin. And that's the whole, way that we remove smear layer. And if you soften the dentin and you are filing a curved canal, you will perforate that canal. You will transport that canal. You will do some nasty things. So if I have a calcified case, I never put EDTA within the canal, because I'm hand-picking my way with hand files 6, 8, 10, 6, 8, 10, so I can achieve patency. And if I have EDTA in there on a curved canal, I'm going to go right out, straight out the side of that tooth. So please never file using EDTA. That was a great question. I really, really like that. I have a question here, I believe, from Michael. He says, do you believe in single visit treatment for most cases? I do. I do believe in it. If I have a large or basically a visible periapical lesion that's more than, let's say, 2 to 3 millimeters in size, I will two-step my case with calcium hydroxide. If I have purulence, exudate coming from the canals, I will place calcium hydroxide. If I have a hyperemic pulp that will not stop bleeding, I will place calcium hydroxide. Any facial swelling, any sinus tract, I will two-step that case. I hope that answers your question. Howard, we have Howard. It says, I have used a sterilizer. What is this? bed sterilizer to sterilize file when I remove file from the mouth, then use another size file. Longer being made. What do you do to sterilize files as you okay? As I change files, we use hypochlorite to sterilize our files. I think the question is, how do I sterilize my files during treatment? They're constantly in hypochlorite. Anything in hypochlorite, a 1-minute application of hypochlorite on anything will render it sterile. I hope that helps your question. I have a question here from Amoya James. Do you use any type of lubricant in calcified canals? Hypochlorite, ladies and gentlemen. That is my lubricant, hypochlorite. You can use a gel like Files or RC Prep, those kinds of things. Those are okay. They have a little bit of EDTA in them, and that may, again, get you into trouble. But honestly, folks, if you are a general practitioner and you are struggling with a case and a 10 file is not going down, please stop. Please stop. Dry the canal, place some calcium, sterile cotton pellet, provisional restoration, lighten the occlusion, put the patient on an anti-inflammatory, 600 milligrams of ibuprofen every 6 hours, reassure them, and direct them to an endodontist. It is not worth your time. Please don't struggle with 6, 8 files and stuff like that. In my opinion, you guys are more productive doing other stuff like crown and bridge and so on and so forth, or going out and enjoying time with your friends and family. I have a question here from David. David says, do you use RC Prep when going to length with hand files? Yes, sometimes I do, David. And you know what's good is if you use something like RC Prep, which I don't really like RC Prep. I prefer more the gels and so on and so forth. I use that during my apex locator time when I'm trying to get length. The RC Prep and the Files and stuff like that helps establish a better contact with the file and the canal walls, giving you a more accurate reading on your electronic apex locator. So highly recommend that. Never want to put hypo in the canal while you're trying to use your apex locator because it's going to start to jump around and it affects things. Fantastic questions, folks. Mandy here says, is it possible that a patient can have pain or sensitivity after root canal treatment? Absolutely, yes. They can have pain, apical periodontitis, yes. But hot and cold, I have seen a few where the patients come back after a general dentist has done the case. And honestly, that usually is in a case where there's inadequate shaping of the canal. I can see very thin, slender canals, barely been shaped, probably some remnants of pulp tissue still present. When I go in there and shape it properly to, let's say, 30, 35, 06, then I've eliminated everything. And we can get rid of that cold sensitivity. But most of the time, no, patients will not have cold sensitivity even after mediocre endo. Now, apical periodontitis, getting rid of that is very, very difficult, and that's when you really have to cleanse the canal properly. I have a question here from Emilio. Are all apex locators accurate, like Neosone? Neosone, I'm not familiar with that one. Listen, most apex locators are pretty accurate. Actually, the most accurate way to achieve your working length is via an electronic apex locator. Root ZX is the one that's the most common, the most famous, by Jay Morita. But there's other ones on the market. If you use them correctly, with, for example, some RC Prep within the canal, the apex locator is the way to go. Your working length film may be too long, and you may be already out of the canal. So try to rely on your apex locator as much as possible. Nasreen here, we have 58 seconds left. If the canal was calcified, do you put gel EDTA inside the canal between 2 appointments? Never, never, never do that. That is a anecdotal thing. It does not help you. You will chelate the canals too much, and you'll have softened canals, and you're going to perforate. Please don't do that. If you can't find the canals, I love you, but refer to an endodontist. Do I have an opinion why we see cases with canals filled very short and patients free of symptoms for years? I wish I had a reason for that. You know, I don't. There's many different factors that go into effect, but please try to go all the way to length. We can achieve it today. Believe me, we can. Email me with questions. It's on the screen. If vertical fracture occurs during root canal treatment, which is the best way to diagnose? Good Lord. I hope you're not getting that. I got to go. Thank you so much, everybody. Thank you. Bye-bye.